Hands, am I looking okay?
Yeah, you're looking okay. We are going live now. We are going live in, yeah, three, two, one. You can begin.
Okay, so good evening and welcome yet again to our series of webinars. I am Dr. Nikhil Bangale, Medical Affairs, Nestle Health Science. Firstly and primarily wanted to thank all of the participants for joining in for today's session. And I really hope that all safe and healthy at your end. Uh, what about today's topic then? What's the session all about? We all know the importance and the criticality of infusing the right nutritional support, especially in an ICU setup. The endeavor and the objective then is clearly being to propel and hasten the patient recovery by giving the right and appropriate nutritional practices. That's what we are here to discuss. And how would it then be structured if you try and have a proper nutritional protocol? What's the benefit of that? And to steer this session, who better than the very, very renowned Dr. Sanjeet Sasidharan from Mumbai? It's a pleasure and honor to have you, sir. Thank you, firstly, so much for taking out time from your extremely hectic and extremely tiring schedule. I can see you're just out of the ICU. Thank you so much for taking out time and sharing these your insights with the viewers. I'll just quickly introduce you. Dr. Sanjeet Sasidharan is the head of the department critical care at SL Raheja Hospital in Mumbai. Sir is associated as a faculty with Indian Diploma in Critical Care Medicine course from the Indian Society of Critical Care Medicine, or the ISCCM. He has received multiple awards for his innovation, especially the iNutrimon, unique nutrition support software in the critical care domain. Dr. Sanjeet was honored for the best original research paper in the Emirates Critical Care Conference in Dubai. And under Dr. Sanjeet's supreme leadership, SL Raheja Hospital Intensive Care Unit was recognized amongst the world's top 15 institutes in the field of nutritional support in critical care in a survey conducted by the Canadian Nutrition Society. It's indeed an honor to have you, sir. And before we start, I would request the participant to put forth their questions in the dialog box that you can see. I will be compiling them and putting them forth to Dr. Sanjeet post his session. Over to you, sir.
Thank you, Nikhil. Thank you very much. All right.
Yes, sir. Slideshow mode, and you can continue.
Yeah. So thank you very much to Nestle Health Sciences and Doc Mode for putting this initiative ahead at this a very trying and testing time for the whole of India, rather the whole world. I mean, we are in the middle of pandemic, and here is where all our knowledge, our experience, and care would go a long way to improve mankind, really. So if you look at the coronavirus situation report that is released today, it shows that it's really spreading like mad right from the time of 30th December. If you look at 13th April, we've got a large number of countries, and America features quite high up there. So we have almost 19 lakhs or 1 crore 19 lakhs 91,199 1562 total number of patients today, and a large number of deaths that have taken place because of this all over the world. 202 countries affected, and counting still. Well, what happens in India? This is what's happening in India as of now. So this is the situation report that was released in India on April 12th. Every 4 days they release a report. The next report will probably come tomorrow, where India notified a COVID epidemic on 14th March, and we've really been going up really leaps and bounds in this case. And on 12th of April, we had 8,447 confirmed cases, 273 deaths. Uh, Very, very trying and testing times. And this is what it is till yesterday. So it's just gone up. I mean, look at on the 1st of February to 15th of April, we now are standing at 12,380 cases. That is in spite of sampling so less. We are really going up. And if you look at this, this is very, very peculiar. We are having Maharashtra going up more than any other part of India. So if you look at it, Maharashtra is going up crazily up, crazily up. We've got a large number of patients coming in from Maharashtra. And if you look at Maharashtra, it's India, it's Mumbai. Mumbai has 1,896 total cases. I mean, it's crazy to have so many cases at one particular place, and we are grappling with a large number of very ill patients. Um, if you look at the case distribution, what is very interesting is uh, it's the case group between 20 to 40 age that are really getting the larger amount of infection that we're picking up. Very clearly, the age group between 20 to 40 seems to be the category of patients that are getting infected quite quickly. This probably maybe because of the fact that they're more mobile, and in spite of having these lockdowns, they probably are roaming around, is what it looks like. But what's more interesting is it is the category from 50 to 80 that are dying. In fact, look at the mortality rate of those patients of above 50. It goes up steeply, 13%, 21%, and 22.2%. I mean, it's 1 in 5 dying. That's just too much. It's too much of a mortality in the age group that lies between 50 and 80. And if you look at this survey that came out from Pune a year before last, it said that the maximum malnourishment seen in adults is in that particular age group. That's somewhere between 60 and 80. This indicates that there's something to do with malnourishment and the age of these people who are dying. So there is some sort of relationship, and probably at the end of this epidemic, maybe a year or two later, we probably see this kind of relationship coming up. But certainly among the adult population, it does appear that the 59 onwards till 80 age group is the one that are more malnourished, and similar to that, this is the same age group that are dying in in the COVID epidemic. Now, what's this COVID all about? And since this is a nutrition update, it's very important to understand COVID, to take COVID in the background to understand this part of nutrition. Well, it is extremely hyperinflated inflammatory condition, which causes an extreme release of cytokines, interleukins, specifically interleukin 6, and this per se is known to cause a large number of problems in our patients. And if you know very well, that would probably lead to hypermetabolism, hypercatabolism, and all the problems that are associated with COVID-19, specifically akin to something called as a cytokine storm that occurs when interleukins go up very high up. And this per se causes probable hypermetabolism, probable an increase in the BMR, and probably causes huge catabolic load on the body, causing muscle wasting is what it looks like. Well, if you look at a study that came out from a systemic review, it is again saying the same thing. The more complicated the patient is, the higher the interleukins. Very clearly showing that it is a hyperinflammatory state, and it's not like any other viruses like the SARS or the MERS or something like that. This is something very different and peculiar. Large number of inflammation, large amount of IL-6, and probably a hypercatabolic state. This might be the one that is dropping down the nutritional value of this particular patient, and hence this consequence of an excessive host immune response and autoimmune injury may be leading to this extreme malnourished state that occurs post the 3-4 weeks of ventilation that we've seen in China, in Italy, we are now seeing in India, things like that. So this intense cytokine storm leads to the collapse of the homeostasis, leading to the manifestation of ARDS. Okay, so this is what COVID is all about. Well, what does that do to nutrition? Well, it does cause increased calorie expenditure. Now, you will see data from my institute very quickly on the caloric expenditure. We've at the moment very few number of cases, but as time goes, we're going to see this data coming up from my institute. because we do monitor indirect calorimetry, and the calorie expenditure coming up. Okay, it does have adverse effects on pulmonary systems. Now, this is very, very important, because when you say nutrition, we're looking at carbohydrate loads, we're looking at carbon dioxide production, we're looking at consumption of oxygen, and things like that is what you're looking at. Hence, probably designer nutritions might be of benefit in this kind of a situation. They promotes loss of lean body mass. It's to the tune of around 15 to 16 kilogram body weight loss is seen in patients from China, and they've documented almost 20% weight loss among people coming out of 2 weeks of ventilation. It's amazing. It's amazingly catabolic is what it looks like. And this per se dysregulates immune function. So this probably is one of the impetus that nutrition has, where nutrition can be used as therapy to try to prevent the dysregulation of immune function in these cases. Now, what's different in nutrition and COVID? Well, what we're now doing is cluster care. I mean, we are trying to group total parenteral nutrition, enteral nutrition, the way to give it together with the medication, so that we go lesser and lesser to the patient. So that if you have to give an IV medication, if you have to give oral medication, if you have to do an investigation, plus if you want to give an added TPN or something like that, a supplemental, or you want to give enteral nutrition, we try to club them all together, so that we reduce our time that we go and towards the patient, because these patients, as you know, are very, very contagious. Nasogastric tube insertions, these are things that we are trying to avoid as of now, because they are potentially aerosolization procedures, and that's the reason that we are now veering faster and faster towards parenteral nutrition. Setting up gastric feeding pumps along with other infusion pumps is what we're doing as a part of cluster care, and we're not doing it at different time spans. The time that we do all of them together. Now, what's also very, very different for the nutrition world is that dietitian rounds are almost off now. We aren't getting dietitians coming in, and that's probably because of the lockdown, and two, because of the fear of having to have problems probably if getting inside, because they aren't really ready to wear personal protective equipment, and it's something that is a difficult task for a dietitian to get in and take rounds with us as of now. So we are facing these problems where dietitians aren't joining us on rounds. There is hardly any patient feedback. These patients are barely breathing, so there is no patient feedback. One of the ways to figure out whether the patient is eating, not eating, is a patient feedback. Unfortunately, in this kind of disease, we are unable to get this patient feedback because patients are grossly sick, and they are hypoxic. And at that moment, the patient feedback is not something that we are getting quickly. The service times are reduced. Initially, we used to have feeding that was done on every 2 hours or every 4 hours, depending on what the patient requires. But now the service times have reduced, because every time you go inside, we need to be completely protected by personal protective equipment. And we are unable to do that because we might just run out of supplies. And that's the reason that service times are kind of reduced. And frankly, doctors don't have the time for this. So that's making it even more difficult, because doctors are so busy cranking up ventilators, so busy getting up the blood pressure, so busy putting up lines to get the dialysis going, that this now the nutrition has actually taken a big backseat in many, many hospitals all over the world. In fact, a webinar that I did just yesterday, when I chronicled this entire thing with Spanish colleagues and UK colleagues, they're barely really concentrating on nutrition there, because of the fact that this disease is so severe and so fast that we don't have the time for doing most of that. And moreover, here is where the biggest problem starts. Poor education, that makes it even more difficult. Now it is very clear that doctors on bedsides are extremely poor when it comes to nutrition. And that is the reason that nutrition is taking a very, very big backseat. Also, we want to limit the exposure, and that is the reason that if units were actually checking gastric residual volumes, we stopped doing that. In fact, initially the recommendation was to avoid checking gastric residual volumes. Now they are forced not to check gastric residual volumes, because they just don't want to go towards the patient, because this will cause more amount of exposure. As of now, mixing and matching is something that we don't want. We want ready to hang solution. Fixed formulations with variable add-ons is very, very important nowadays. We are adding oral nutritional supplements right from day one, because we just don't want to get back on the proteins. There's a preference of TPN in NIV patients. These patients can hardly breathe, let alone eat. Putting that Trials tube or that nasogastric tube through the nose when the patient is hardly breathing makes it a tough task, and B, it causes so much of leak that our NIV doesn't work. And that's the reason that we probably are veering towards a sign of supplemental parental or partial parental nutrition in patients on the NIV and refraining from enteral nutrition. And there is so much of diarrhea that we are trying to improve this situation by bulking with fiber, very high fiber rich nutrition in these cases, and it still is not making too much of difference. Look at this graph is actually showing what happens to what's going to happen to India. See, India is the black line that we're seeing over there. It follows Washington, the blue lines. So it is following Washington, and as time goes, I feel these cases are going to just increase majorly, and by epidemiological data that came out on April 2nd, it's clear that we're going to be in a situation where we're going to be in a we're going to see a large number of patients that are going to come in. And if the lockdown is successful, even if it affects to 30%, we still are going to see a large number. So the large number is going to be there. There's going to be a large number of sick patients at home. There's going to be sick patients in the hospital. There's going to be critical patients in the ICU. And it is inevitable that this is going to occur. It's already occurring, and we are bearing it. And that's the reason that what is sure is what I'm putting on the slide. Number of cases will increase. Number of hospitalization will increase. Number of critically ill will increase. The average length of stay will increase. Manpower will be short, and this is very important because our service areas, our kitchens, our dietitians, this manpower will probably become short. Overwork will be commonplace. Human errors will increase, and work is already become stressful. It will become even more stressful for certain. And that's why, to improve efficiency, there's only one thing that we can do, and that's protocolization. Um, that's what we've done. We've put a nutrition protocol in place. Anyone who wants to read it can probably read it from the website. And it's important to know that something that looks like a protocol but does not accomplish a task is not a protocol. It's a waste of time. And that is why we need to identify the right protocol or the right way to feed these patients. So let me get to this trial. This trial was called the FEED trial. This trial came out in 2018, towards the end of 2018. And Feta Place went ahead to do this trial. Why did she do this trial? Targeted full energy and protein delivery in critically ill patients, a pilot randomized controlled trial. Why did she do this trial? Well, if you look at the data that comes out from India, very clearly we have a large population of high-risk malnourished patients. Already, we're not even thinking of COVID, but it's already a high-risk malnourished population that we have. And this high-risk population clearly shows higher mortality. That means the higher the population risk for malnutrition, they have higher the mortality. This is what is very clear. So pre-existing malnutrition is there, very prevalent in our country. And even then, if we try feeding them, we know that we are feeding them with lesser proteins. That is what is required, and that's what is called as iatrogenic underfeeding. This is data from my hospital, where we really follow a large number of protocols. In the past, we still had a large number of iatrogenic underfeeding, which I'll tell you why we've gone away from this problem. So does volume target make a difference? And this is the question that Feta Place wanted to answer by the FEED trial. Now, what was this FEED trial? What they did was they had a high protein enteral formula feed. The nurse's order included a volume target. That means a volume target was delivered over 24 hours. That's what they were given, the volume target. At 4 p.m., the nurses assessed the volume remaining. So what would have happened was patients were going to the scanners, patients were going to get some procedures done, and feeding was stopped. But at 4 p.m. every day, the nurses assessed the volume remaining. And then the delivery was done over the next 8 hours with a max rate that was capped at 150 ml per hour. And they looked at the admission diagnosis, the Charlson Comorbidity Index, CATS Activities of Daily Living Index, Apache 2, 3 SOFAs, duration of ICU, hospital admissions, discharge destinations, and survival at 28 and 60 days were recorded. I mean, they looked at very hard points when they looked at this trial to understand whether volume-based protocol, whether that makes a difference. In this trial, they looked at a large number of patients that were excluded, surprisingly, in this trial, and they went up to only 30 plus 30 in both the arms that looked at volume-based feeding versus the usual feeding. And when you looked at the intervention and stand, the intervention here is volume-based feeding, the groups were very, very well matched for age, for sex, for body mass index, for Apache scores, CATS activity. So there was nothing wrong with the way they randomized these patients. They were very, very well matched, and we were comparing apples to apples. It was not a wrong comparison. What they did find was something phenomenal. They did find that the protein delivery grams per kilogram did go up very, very to very, very high amounts. I mean, they were initially at zero point 0.6 with standards, and they started going up to 1.2 to almost 1.5 gram per kilogram, which is it's amazing. And this didn't cause a huge change in the calories. So this is what we want: higher proteins, lower calories. Now, when they looked at the data as to the outcome variables, what they found was there was hardly any difference between patients who were fed by volume-based feeding versus the ones that were standard fed. I mean, with respect to intolerance, there was nothing to think between them. Both were absolutely the same. What they also found was there was no increase in diarrhea among both the groups. That means both those groups, irrespective of the volume-based feeding or the standard nutrition, they were comparable, indicating that if you were to increase volumes, it doesn't cause diarrhea. Now, this is what the entire world feels. I mean, this is what surgical world feels. You increase the volumes, and the patient will have diarrhea. But that is not what occurred in this trial, very clearly indicating that what we've been doing all these years by just increasing volume and thinking that was diarrhea was actually wrong. In fact, when you increase the feed, it probably increases the protein load, is what it looks like, at least by this study, very clearly indicating an increase. Or the mid-arm circumference didn't really change at all. In fact, it increased in the intervention arm. I mean, it did not decrease too much in the intervention arm, indicating that these proteins were getting assimilated. Very similar to that, the hospital length of stay, such an important metric, it changed quite a bit, and the length of mechanical ventilation days did change. So what we infer from here is volume-based feeding causes more protein delivery. It does cause a little bit more energy, but not commensurate to that of proteins. There is a reduction in loss of muscle mass, and there is reduced malnutrition and discharge. So this is certain. This is certain that volume-based feeding does definitely do something. So there's another trial that was subsequently done, a feed me trial. This feed me trial also did something very similar to this. And what they found out, rate versus volume, the graph on the right is the volume-based protocol, where they found out that the percent of volume delivered was towards 80 to 100% when they actually did the volume-based protocol. Whereas when they did the rate-based protocol, it did not attend to around 80 to 100%. They started at 30, 40 and slowly started building up to 100% at what it looks like. And very clearly, this also showed that rate-based feeding had 1.13 plus or minus 0.25 grams per kilogram of actual body weight proteins that were delivered versus 1.26 in the feed B group, clearly indicating that proteins definitely go up. And this is the trial that came out maybe 8-9 years ago, in fact longer than that, which actually started this entire discussion on enhanced protein energy provision via the enteral route by the protocol called as a famous PEPA protocol. And when you compared the feed me to the PEPA protocol, it just looked like the feed me protocol was specifically to ensure that people don't get worried about the maximum hourly infusion rates. For example, here was 120 ml per hour, whereas the PEPA went to 150 ml per hour. Surgeons probably may not have liked that. And that's probably the feed me protocol, even though it's volume based, is still very comfortable because maximum hourly infusion rate being around 120 ml per hour. And the gastric feeding maximum was 400 ml every 4 hours, whereas there in PEPA it was 600 ml. So this, I would put it this way, that the feed me protocol was more friendlier as compared to the PEPA protocol. The feed me protocol used a variety of products. It didn't need a specific product. Whereas the PEPA protocol required a semi-elemental formula. And that's probably the reason that these patients also were able to tolerate larger rates. So if you were to ask me, in a volume-based protocol, which particular formula would be better, I would still look at this study and think that the PEPA protocol was a little bit better on these cases, and semi-elemental formula specifically would be something that would be better because of the fact that the tolerance level was high, the feeding maximum could be maximized, and the use of pro-motility agents was not really too much, even if you used the PEPA protocol with these high volume-based equations. But at the end of the day, volume-based feeding was definitely the way to go. In this aspect, it's very important to allude this to this trial that came out some months back in the Japan. This was a safety and efficacy of volume-based feeding in critically ill, mechanically ventilated adults using the protein and energy requirements fed for every critically ill patient every time. Perfect protocol. Now, this is the category of patients that are so important for us because this is what we're dealing with presently. Patients who are ventilated, patients who are on the ventilator for a long period of time. In this category of patients, in this subgroup of patients, would it make a difference if we used a volume-based protocol? And now the whole world is looking at this subgroup of patients because COVID is that group of patients where they are mechanically ventilated, and that's the load that is in the hospital. So, for example, what is this feeding protocol? For example, if you had 1,000 to 1,200 ml that volume feed you want to start at for 24 hours, it would be 50 ml per hour at 8 hours. If the patient's feed was off for 8 hours and he had received 400 ml of feed prior and they remained 8 hours, all you needed to do was subtract it. The remaining 800 ml would be given over 8 hours at 100 ml per hour. And 50 ml would again commence on the 8 hours later on. The difference between the PEPA was they did not use prophylactic prokinetics. They didn't increase the amount of protein supplements, and all that they used was baseline semi-elemental feeds. This is what they used. They borrowed that from the PEPUP, but they did not use prokinetics. They didn't use most of the other fanfare that PEPUP did. And then they found out some very important results. Now look at this. The volume-based protocol achieved a very large protein delivery to these patients as compared to the rate-based protocol. So important in this particular junction when we want the proteins to go up, especially in those patients who are mechanically ventilated, losing weight and hypercatabolic. And what's most important from all this is that it did cause some kind of reduction in the days from in the ICU, and it made these patients get extubated out faster. In fact, the days on mechanical ventilation was much shorter. Now, this is so very important. We are dealing with a situation where ventilators are hard to come by. We are barely getting any ventilators. So at that stage, if the patient does come off the ventilator quickly, that's what life is all about in this pandemic. You get off the patient off the ventilator, this ventilator goes to another patient. We save more lives. So if the volume-based protocol is responsible for getting off the ventilator quickly, then we save more lives. In short, the perfect protocol or the volume-based protocol would save lives. So it's very important that we understand this very simple thing called as volume-based strategies in order to improve proteins in these patients. There were two subsequent guidelines that came up in COVID-19 disease from the ASPEN and the ASPEN back-to-back somewhere around the start of April, start of this month. But both of them had three very important points, and I'll allude to those 3 points, which indicated that you need to supplement them with vitamins and minerals right from the start. Now, this is something that is seen in the European countries. Most of the Afro-American nations have witnessed that there's been marked drop in vitamin D's in patients who are entering into the COVID spectrum of diseases. Vitamin A's are also low, and so they've advised to start supplementing it right early in the illness. The other thing that they have mentioned is to give ONS whenever possible to meet patients' needs. That means it has now re-emphasized the fact that just usual feeding is not enough. You need to add oral nutritional supplements that are sufficient enough to increase dietary intake and reach nutritional goals. So that means all patients that are admitted into the hospital or into the ICUs will be needed to start oral nutrition supplements right from day one is what it looks like. And most importantly, it says many of these patients are going into dysphagia. That's probably because of the fact that we give prone position to them. They're ventilated for a long period of time. It's very difficult for them to eat later on because of the fact that they're swelling all around the neck. And it stresses upon the fact to feed these patients in a very different way. So I'm certain that many of my doctors who are working with COVID, I think there are 5 or 6 major hospitals in Bombay at least working COVID, and a couple of them outside India too, outside Maharashtra too, that there is too much of GI upset that occurs. There's some amount of hemorrhagic gastritis. All this leads to gastric residual volumes going up. It's very, very clear in COVID patients. Many manifest with diarrhea. Many are in depression and refuse to eat. Too many drug interactions are there. We're using drugs right, left, center, which is not even evidence based, like HCQ and chloroquine and ritonavir and lopinavir, where the evidence is hardly there. We're using them, and there are too many drug interactions leading to other problems which are related to the GI tract. Dietitians who are a mainstay are really not available now. I mean, they are there in the kitchens, but I think they are. It's practically. I don't see them in the ICUs or the wards because I think they are scared to wear these personal protective equipments, and probably even the CEOs of hospitals are trying to restrict giving them the PPEs to go in front of patients because it's needed for other healthcare workers who are dealing on the front line. And there's so much to do in this epidemic. We need to work fast. And what we've done is something very, very important during the start of the epidemic is we've protocolized everything in feeding, protocolized right from start to the end, so that the dietitian can sit at home, sit in the office, and deliver everything without a problem because of artificial intelligence and machine learning that we've gone through. Protocols. This is the protocol that we're using. Of course, if you want to read this protocol, you can go to the website called as drsanjit.com. A simple protocol to be used, volume based, in order to improve the protein load that is getting into the patient. And artificial intelligence, this is something that I think everybody should use. I think every dietitian should use this because of the fact that this is completely away from the ICU, completely away from the bedside, completely away from everywhere. I mean, with this, you can calculate, you can suggest, you can define, and you can monitor these patients sitting in the comfort of your room, away from those patients who are contagious, and deliver a nutrition chart bedside only for the nurse to use it, limiting PPE, limiting the number of people going bedside, and thus achieving our FAR goals, which indicates proteins and volume-based nutrition. I think this is something that has helped me quite a bit. I mean, I didn't think that this would be of so help, but at this moment, I can vouch for the fact that the iNutrimon has definitely helped me. It's not because I was part of the invention here, but it's because it is helping me at this particular moment to ensure adequate, perfect monitoring and optimization of nutrition in my ICU. Well, I'm telling you, I'm going to give up data very quickly on hypermetabolism. I'm going to give up data on stages in illness, resting energy expenditure in cytokine storms, and otherwise VCO2 production, VO2 consumption. Well, we're too early in the epidemic, but probably in say a month's time from now, you would see probably data coming from my center. Please watch the space. So it's very important to understand that volume-based feeding strategy significantly improve the likelihood of consistently achieving daily feed targets in all patients. More importantly, it optimizes protein delivery. That is what we have seen across the studies, across all studies. Of course, the way forward will be large multi-center randomized controlled trials to measure outcomes related to improved protein delivery, adequately powered samples for pre-specified effect sizes, a priori determining patient outcomes. Of course, there's time for this, but as of now, there is clear evidence indicating that volume-based feeding protocols will help to optimize protein delivery, which is presently the need of the hour. Thank you very much. And if you want to have a look at my protocols, if you want to look at more information on various other matters of nutrition or COVID, you can definitely log on to drsanjit.com. It's a free website, purely academic for the nature of for helping you all in the academic world. Thank you very much.
Thank you so much, Dr. Sanjeet, for that talk. And I think very clearly, volume-based feeding is something that is one of the imperatives today. You've clearly shown the benefits in terms of protocols and effects into practical as well as the clinical outcomes. There are a few questions which I'll quickly put forth to you. One is what kind of supplements are preferred as first line in the ICU patients, especially in the current scenario?
All right. So a very, very intelligent question and very difficult answer to give. Now, what we've noticed is we are at this moment in a trial stage. What we are doing now is we are trying different supplements. And what we've noticed is the easiest supplement that can be kept in and not come out is the semi-elemental supplements. And we've been veering towards peptamen quite a bit as of now, because it seems more tolerable compared to the others. I did not want to give up names, but this is practically what is happening. I did use whole protein formulas, and for some reason these patients don't tolerate them. They have vomiting, and when the patient vomits, the whole ICU goes into a dizzy, because now there's going to be aerosol generation. I need something that will not have vomiting, not have diarrhea, and is easy for the patient to drink. So I think, and I think at the moment, I think the way to go is semi-elemental formula per se. Yeah.
Okay, so thanks for that, sir. One more question. So we spoke a lot on proteins and calories, and there's a very pertinent question on micronutrients now. How
Mhm.
important is the role of micronutrients under the current circumstances?
So, there are a few colleagues whom I spoken to last night. Last night we had a webinar on nutrition with a few colleagues of ours, and when we stressed upon the fact about selenium and magnesium and zinc and all the elements, I think at this moment this is quite on the back seat, and only time will tell whether this is going to make a difference. I am aware that there are trials going on in the city of Bombay where we are looking at zinc. And selenium in these cases, but it's a far call. So as of now, I don't think there is a specific a reason to believe that this may make big difference. In fact, at this moment, it's more of ventilation and proteins and macronutrients rather than micronutrients. But yes, the question is very pertinent, and probably in the time to come, we might see some suggestion of and I believe such things would probably work. And since nothing is working, I think nutrition is going to be the key in the future for this kind of disease.
Sure, sir. Thanks. One last question, if I may ask. What is the role of MCTs then as part of nutrition in the ICU? Again, in the current circumstances, any guidelines or any kind of evidence which,
So,
helps?
so, so yes, that's a very good question, and in fact, this is what therapy is all about. Nutrition not taken as a food, taken as therapy. Um, there is some evidence that is coming up from Wuhan and the Hubei province, where they actually used MCTs, and they did find out that the amount of inflammation seen post CT scans after doing CT scans was much lesser. Now, whether that was related to the MCT or whether that was related to the treatment or whether related to ventilation, we're not certain about it. But there are a few papers coming out talking about MCTs and reduction of inflammation and stuff that way. But we are too far away from the evidence in this regards too. And I think time will tell whether this is going to make a difference. Yeah.
Sure. Thanks, sir. And I think I won't keep you waiting. I know that you probably want to get back, but one last question, one final question is, what's your take on conditionally essential amino acids, sir?
Right. So, if you are looking at conditional essential amino like glutamine, um, well, glutamine can be taken as a nutritional supplement because it's a high power, high energy kind of a high power kind of a protein formula that can be given even IV for that matter. Uh, and it might be making a big difference now because according to the current scenario, this hypermetabolic response might make this a conditionally essential amino acids as quickly as essential as possible is what I feel. But you must understand that a small population, 10% of this population are those people who are going into renal failure, 10% of the population. So this kind of patients have to be very, very careful. You be very careful before we go into giving the glutamine to all these patients, because you might end up with a patient who is already having renal failure, and without even thinking, if you give these patients a truckload of glutamine, you probably incite this patient going into CRRT, renal replacement therapies, and things that way. But essentially, COVID is a single organ insufficiency, and multi-system organ insufficiency is a terminal phase. So when in the event of a single organ insufficiency, it makes a lot of sense actually to use this conditionally essential amino acids like glutamine, because this might be a turning point in the future. I'm certain that the future holds a lot of promise for nutritional therapy and nutrition as therapy rather than nutrition as food. Yeah.
Sure, sir. Right. I think with this, we will conclude today's session. Thank you so much once again, sir. As a frontline worker, thank you so much for all the work, phenomenal efforts, and I just hope that things will settle down globally as well as in India. Thank you so much for taking time out and giving this talk. It really means a lot, speaks volumes about your dedication towards this science. And of course, thanks to all the participants as well who took time out and attended today's session. So thanks a lot, sir. Any concluding words from you for this session?
Yeah, so I say stay at home, be safe, and I don't venture out any moment, please, because that's the only thing that you can help us with. Thank you very much.
Thank you, sir. Thanks.